Physical activity and proper nutrition have for a long time been associated with improved physiological functioning and health. Greek physicians Hippocrates and Galen were strong believers in disease being the product of external influences and living habits. This linkage has come a long way in the last 2,000 years and owes this to a number of notable scientists throughout this time. Present-day exercise intervention is used for maintenance and improvements to health, improved sporting capabilities, and more importantly in the management of chronic disease. Chronic disease has been associated as the underlying cause in 9 out of every 10 deaths in Australia. Health expenditure for the top 4 chronic diseases was $27 billion in 2008 to 2009. This figure does not factor further costs to the community, such as the loss in productivity. The high burden of chronic disease in Australia in terms of lowered health status and increased economic expenditure means it is an area that should be targeted through government policy. A number of these chronic diseases are the result of lifestyle factors which can be largely avoided or changed through the implementation of increased physical activity. Exercise intervention has been shown to improve musculoskeletal pain, postural and muscular imbalances, cardiovascular rehabilitation, cardiopulmonary function, and symptoms of metabolic disorders. This presentation is going to focus on the benefits of exercise in the prevention and management of coronary heart disease, chronic obstructive pulmonary disease, and metabolic disorders, specifically diabetes. Physical activity recommendations for each disorder will also be included using the FIT principle. The primary objective of exercise prescription is to lower the physiological limitations and improve physical capacities of a patient suffering a chronic disease. Exercise for patients with a chronic illness should be implemented using a problem-oriented approach to exercise management. PALM allows practitioners to be able to define and solve more complex problems into simpler variables which can be more easily tracked, meaning that exercise intervention should be tailored to suit the specific needs and capabilities of the client. The 5 steps of PALM include collection of subjective data, collection of objective data, assessment and generation of problem list, formulation of a plan, and periodic reassessment. Like medical intervention, there are certain types and dosages which maximize the benefits from such treatment. Exercise needs to be prescribed to maximize benefits and reduce any adverse effects training can have, such as overtraining and its impact on recovery, as well as psychological and physical degradation. Aside from the pathophysiological benefits from exercise, significant remunerations are made economically because physical activity is relatively cheap when compared to pharmaceutical intervention, and there are few limiting factors to participating in some form of physical activity. As can be seen in the following table, the burden on Australia, both economically and the loss of productive life, is significant. 35% of Australians live with at least one chronic disease. The top 4 chronic diseases account for 40% of allocated health expenditure. Coronary heart disease and COPD account for 11.3% of disability-adjusted life years. Diabetes is diagnosed in approximately 1 million Australian adults over 25 years of age, with projections close to 2 to 2.9 million cases by 2025. The annual costs associated with type 2 diabetes in Australia were $10.6 billion in 2005. With current projections, this cost could potentially triple in 15 to 20 years. The high prevalence and costs associated with type 2 diabetes make it an important issue for the Australian healthcare system and general population. Proper education and behavioural change is needed to ensure lifestyle factors are chosen from a young age as a means of reducing the considerable impact that diabetes has on the community. Benefits of sustained aerobic and resistance training include improved cardiovascular fitness, increased muscle mass and strength, and a reduction in body fat. These factors assist in the management of diabetes mellitus 2 by improving glucose uptake, resulting from better circulation and increased exposure to lean muscle. The proper management of diabetes is important because of the potential for macrovascular and microvascular complications developing. The main objective of exercise intervention in this population is to improve the blood glucose profile of a client with type 2 diabetes. This can be achieved by implementing an exercise program as part of the combined intervention targeting the disease. An improved blood glucose profile will lead to an overall better quality of life and assist in minimizing the risk of neuropathies developing. The glycemic targets for diabetics as stated by the American Diabetes Association include a fasting glucose less than 100 milligrams per deciliter, a 2-hour plasma glucose of less than 180 milligrams per deciliter, and a glycated hemoglobin percentage of less than 7%. Exercise programs should also aim to reduce the client's waist circumference. The criteria for adult waist circumferences for the American College of Sports Medicine identify a waist circumference greater than 120 centimeters as being at a very high risk of developing coronary heart disease and type 2 diabetes. Exercise prescription for diabetes will follow specific guidelines described in the American College of Sports Medicine, which states aerobic exercise should be done on 3 to 7 days of the week for 20 to 60 minutes, totaling 150 minutes per week. Aerobic exercise should be at 60 to 80% of VO2 reserve, involve large muscle groups and continuous movement bouts of 10 minutes. Resistance training should be done on 3 days of the week with a 24-hour rest period. Exercises should be done in 3 sets of 8 to 12 repetitions at 90 to 100% of 10 RM. Each session should include 8 to 10 multi-joint exercises of all major muscle groups in the body. Considerations for this population should include the potential for hypoglycemia, particularly in patients who take exogenous insulin medication. This can be avoided by monitoring blood glucose levels, altering carbohydrate intake, and the timing of training sessions. Incident rates of chronic obstructive pulmonary disease in Australia have shown that 1.49 million Australians over the age of 40 have some form of COPD. COPD is progressive disease which restricts the respiratory system and commonly results in a shortness of breath. Common conditions of COPD include emphysema, chronic bronchitis, and chronic asthma. The main causes of COPD are smoking, genes, exposure to particles, occupational dust, indoor and outdoor pollution, oxidative stress, and age. Without a known cure for the disease, sufferers can improve their physiological capacities through the implementation of exercise programs. Gosling et al. Have shown that inspiratory muscle training will lead to improvements in respiratory muscular strength and endurance, as well as functional exercise capacities. Exercise intervention in patients with COPD reduces dyspnea, anxiety, and depression, improves exercise capacity and quality of life, and may reduce hospitalization. Increases in function allow sufferers to participate in a wider range of activities within the community, which help to improve their quality of life and contribute to their community. Furthermore, long-term training of up to 18 months was shown to reduce the dosage of disease-related medicines of COPD patients. The proper management of COPD exercise should be tailored to suit the physiological capabilities and goals of the client, whilst adhering to certain guidelines. Exercise prescription to patients with COPD will vary based on the severity of symptoms that the patient suffers. The proposed guidelines are for patients with moderate to severe COPD. Aerobic exercise should be done on 3 to 5 days of the week, progressively increasing intensity with intermittent bouts of exercise until longer, more intense bouts can be sustained. Aerobic exercise should be at 60 to 80% of peak work rates. Exercise should mostly include walking and cycling initially, then incorporating resistance and stretching exercises into training sessions. Resistance exercises should be implemented on at least 2 days of the week, of moderate to vigorous intensity, progressive weight load of major muscle groups, including 8 to 10 exercises with 10 to 15 repetitions. Considerations for this population group include clients experiencing greater dyspnea when performing daily activities. Therefore, particular focus should be given to exercises of the shoulder girdle during resistance exercises. Infantry muscular training should also incorporate. Coronary heart disease is the leading underlying cause of death in Australia, accounting for 15.6% of deaths in males and 13.7% of deaths in females during 2011. Coronary heart disease is a disorder of the arteries around the heart which are needed to supply oxygen and nutrients. The World Health Organization estimates that 20% of worldwide coronary heart disease is due to a lack of physical activity. The main causes of coronary heart disease are smoking, high levels of certain fats and cholesterol in the blood, high blood pressure, high levels of sugar in the blood due to insulin resistance or diabetes, and blood vessel inflammation. Recent studies have shown that physical exercise partially improves endothelial dysfunction and inhibits vasoconstrictors in patients with coronary heart disease. Further physiological benefits which will help to improve coronary heart disease symptoms include improvement of ventricular function and the cardiovascular risk factor profile, including beneficial effects on HDL, cholesterol, blood pressure, and insulin sensitivity. The prescription of exercise to patients with coronary heart disease will be based on outpatient protocols stated by the American College of Sports Medicine. The majority of patients are able to participate in some form of activity 1 to 2 weeks after leaving hospital. Exercise should be done on 4 to 7 days of the week, or multiple 1 to 10 minute bouts increased to full sessions as the patient improves. Weekly increments of 10 to 20% on workout duration should be implemented until full 60-minute workouts can be achieved. Exercise intensity should be at 40 to 60% of heart rate reserve or below ischemic threshold if one has been given. Workouts should include a warm-up and cool-down of light to moderate exercise with static stretching and flexibility exercises. Aerobic exercise should be chosen which is rhythmic and use large muscle groups with the aim of increasing caloric expenditure. Resistance training can be implemented following a 4-week endurance rehabilitation program. Initial resistance should be 30 to 40% of the 1 RM upper body and 50 to 60% of 1 RM for lower body, at 12 to 15 repetitions, including 2 to 4 exercises per major muscle group. Considerations for this population group include patients with sternotomy should restrict weight and range of motion surrounding the incision. Electrocardiograph monitoring of patients should be implemented based on the risk level of the patient. Patients with pacemakers and defibrillators should train at 10% below their safety thresholds. Chronic disease in Australia bears a significant cost to the Australian economy through healthcare expenditure and loss of productivity. A large percentage of chronic illnesses are subject of lifestyle factors which can be largely controlled through the implementation of increased physical activity and nutrition. Proper education of the benefits of physical activity need to be implemented to ensure a holistic approach is incorporated in the treatment of these diseases.